Hi guys, welcome back. The next topic we're studying is diseases of the pericardium, and the first one that I'll explain to you is acute pericarditis. When I ask about the causes of acute pericarditis in a face-to-face class, the usual answers that I get is tuberculosis and rheumatic heart disease. I do agree to that from the Indian perspective, these are important ones. But in the exam, the first answer should be given as idiopathic variety. After that, obviously, the viral pericarditis component should be answered. In fact, with the advent of COVID-19 and the increasing incidence of it and the prevalence of it, COVID-19 pericarditis and COVID-19 myocarditis, both of them are troublesome. And why I'm saying troublesome, especially in the setting of COVID myocarditis. The bad news is because in COVID-19, in severe cases and moderate cases, you are giving steroids. And in a viral replicative phase, when you give steroids, there's a possibility that the damage caused to the heart will increase. So in the forthcoming years, you will notice our topic coming up in the textbook by the name of COVID heart per se. And this COVID heart will mostly be having a dilated kind of cardiomyopathy. So the number one cause is idiopathic, then is viral, then is tuberculosis. And then I'm going to explain to you regarding autoimmune pericarditis. This autoimmune pericarditis is again quite frequently asked, and examiners love to ask about it. Dressler syndrome, which is a late complication of MI. This person has already been discharged from a hospital. Maybe he was a case of STEMI or non-estilation MI, had received proper treatment, was discharged safe and sound. But after 3 to 4 weeks or maybe up to 6 weeks, this person might call you again with a sensation of severe chest pain. He will say, I'm having a sinking sensation. I think I'm going to die. I mean, those are the usual words that patient might actually tell you because he's having severe chest pain, just like kind of that occurred a couple of weeks back when he was diagnosed with a myocardial infarction. Now, because it is autoimmune in etiology, the usual answer for the treatment of this is casually given by people as steroids. But I want you to remember the fact that if you will give steroids in Dressler syndrome, then the healing process will be hampered. You see, since the person had a MI 3 weeks back, maybe 4 weeks, maybe up to 6 weeks back, there is a scar formation that is occurring, and this scar might actually become weaker or may not develop properly in case high dosage of steroids are given. So for the treatment of Dressler syndrome, the first answer should be given as aspirin and not steroids primarily. As I explained to you, this complication will occur 3 to 6 weeks post-MI, and I'll explain to you in a while how and what investigations will you do, what auscultatory findings will be present, so that you can differentiate that whether this is a new episode of MI or whether this is going to be a Dressler syndrome. So differentiation is easily possible. The fifth cause is malignant pericarditis, and this can translate into malignant pericardial effusion. And in fact, this effusion can become so big that it can even translate into cardiac tamponade. Now, what is the difference between pericardial effusion versus cardiac tamponade is what I'll explain to you gradually. But one of the important cancers that can metastasize to the heart any day is oat cell cancer of the lung. It anyway exhibits micromets. Second is going to be breast cancer. So people with these two cancers can be expected in future without treatment to develop a malignant pericardial effusion. The sixth cause is important because uremic pericarditis per se is an absolute indication for hemodialysis. Mark my words there. I said if a person is suffering from uremic pericarditis, the chest pain is going to be so bad that you will have to do a hemodialysis in the patient. If you get a question in which uremic encephalopathy and uremic pericarditis both are given, and you have to select one. Obviously, uremic encephalopathy, pericarditis of uremic variety, both are indications for hemodialysis, but the first answer should always be remembered as uremic pericarditis. In fact, it is an absolute indication for hemodialysis. For uremic pericarditis to develop in a person, GFR will dramatically reduce. So in a case-based scenario, he can definitely initially talk about a person who is having diabetes, who will subsequently go on to develop diabetic nephropathy due to uncontrolled diabetes, and therefore his kidneys will be damaged and GFR will begin to reduce. Normal GFR is 125 ml per minute, 1.73 meter square body surface area. GFR less than 15 is gonna contribute to development of uremia in a person that will necessitate hemodialysis. And the alternative term that is used to describe this GFR of less than 15 is called as end stage renal disease. I just wanted to highlight that he can basically talk about a diabetic person. He'll then talk about the chest pain that is being experienced by this person. This is not due to any coronary event, but it is actually uremic pericarditis since the kidneys of this person have subsequently failed. That is mainly with poor sugar control of HbA1c more than 7%. Now, once we are aware of the causes per se, I will now talk about what is going to be the clinical presentation and how would you differentiate this from a case of myocardial infarction. He will describe an adult individual of varying age groups depending on the etiology. I mean, he can talk about a malnourished individual from rural India with respect to tuberculosis. He can talk about a obese urban Indian who's maybe a diabetic or a non-diabetic and had a myocardial infarction and is now coming to you with Dressler syndrome. So as such, I mean, age or I would say gender or the build of the person will not give you any kind of special information that you can actually identify pericarditis. So I'm not mentioning age group or gender wise data anywhere, and I'm just highlighting that the person is talking about diffuse chest pain, that too at rest. Initially, this person thought that it could be GERD, but see, in gastroesophageal reflux disease, taking antacids will cause relief. And in GERD, anyway, person will point to the chest pain with his finger. In this case, he's going to be pointing with whole of his hand on his chest, or maybe the fist on the chest to describe the diffuse nature of the chest pain. So, first impression of yours will be that this is a coronary event. Now, what is going to be written in the question that will give you an idea that this is unlikely to be a case of coronary event or myocardial infarction is one, the relief. The relief in MI will not come with any position. No, I mean, an MI patient is going to be miserable to the level that the chest pain can contribute to vasovagal syncope. But in this person, he's telling you, sir, I feel better when I sit up, when I lie down, I am very miserable. And then would also be information with respect to radiation of chest pain. In MI, the pain can be very extensive. The pain can radiate also. It can radiate to the jaw. It can radiate into the abdomen, into the right up to the umbilicus. It can radiate into epigastric area. So pain of MI radiates dramatically to multiple sides. But in this case, the pain will be mainly radiating to the shoulder of the patient, preferably or most commonly the left shoulder. So these are some pointers which are telling you that it may not be a myocardial infarction. It may not be, I would say, a coronary event. On auscultation also, you will be getting this classical finding mentioned. He may not write the word pericardial friction rub because then the diagnosis will become so obvious that he has no business of asking you this. So he might say scratchy sound in the chest. Now this scratchy sound in the chest that we are hearing is a pericardial friction rub. If you evaluate a MI patient, S1 will usually be loud due to sympathomimetic stimulation. S2 can be narrow split because of left ventricular failure. But in this case, the S1, S2 intensity wise are normal and the splitting of S2 is also fine. There's no third heart sound being heard. Because you can easily confuse a pericardial friction rub with a pleural rub on auscultation. So I am going to ask my patient to simply hold his breath and count mentally till 5. If a person will hold his breath and the sound persists, then definitely this is pericardial rub, and if the sound disappears on breath holding, it was a pleural rub. Pericardial friction rub on breath holding, it will persist just the way it was. So I have said two things here. On auscultation, I'm trying to differentiate, is this MI? Because obviously heart sounds will definitely be affected in myocardial infarction. In this case, luckily the heart sounds were normal. It was the friction rub present, and I've also differentiated from a pleural rub as well. I would like to at this junction just remind you what I've taught you in acute coronary syndrome also, but just a quick revision here. If a person is having a cardiac event or a coronary event, there will always be diffuse chest pain. Most patients will either keep their whole hand on the left side of the chest or maybe in the center of the chest like this, just to signify. I mean, patient will be in so much of pain that they may not say pain. He's just pointing like this and saying that I am not getting sufficient breath and I just feel I am having a sinking feeling. I don't think so that I'll survive this night. This diffuse chest pain can definitely radiate. So in myocardial infarction, the pain can radiate to the angle of the jaw. It can radiate to the inside of the arm and the forearm. It can also radiate towards the abdomen, towards the umbilicus, or even I would say in the epigastric area or up to the umbilicus. So I'm just putting two arrows here to say that it could be present mainly supraumbilically. Now, the nerves which are involved in this case are multiple. One of them is inferior cervical cardiac nerve. Just a quick revision of anatomy from you guys. That's going to be one of the important nerves carrying the pain. Then is going to be superior cervical cardiac nerve that will carry the pain upwards. And the third one is thoracic splanchnic nerve. Now just look at the name. Splanchnic would tell you that it will be carrying pain towards the abdomen. So these are three nerves which are responsible for carrying the pain with respect to coronary event or myocardial infarction per se. In contrast, or angina, I can say, even if it's a chronic stable angina, chest pain will come on exercise, not on rest. But the point is, whenever there's a coronary etiology which is responsible, these are the nerves which are responsible for carrying the chest pain. Whereas with respect to pericarditis per se, the nerve that would be involved for carrying this pain and especially causing it to be radiated to the left shoulder will be the phrenic nerve. And you very well know about this even from your anatomy discussions. We will now be focusing on what is going to be the ECG findings in this person as well as echocardiography, and I also need to go for etiology as well. When you perform the ECG, one of the characteristic features that will always be written will be ST elevation. In fact, this ST elevation will be concave upwards. I'll hand draw this concave upwards in few seconds from now, and I'll be actually showing you an image also. But at the moment, I want you to remember that unlike a myocardial infarction, in MI, you will be having findings in limited number of leads. Like it is anterior MI, V1 to V4, 1 and AVL. If it is inferior MI, 2, 3 AVF. But in this case, almost all of the leads will be having a ST elevation. So it's going to be diffuse. Why? Because pericarditis inflammation will occur all around the heart, 360 degrees. So that is why ST elevation will be concave upwards in all the leads, and the examiner would definitely love to ask a accepted. Now the accept answer for this would be lead number AVR. The logic is that AVR per se always reads the heart the other way around. What I mean by other way around is that in AVR you would have noticed, even in the ECG and arrhythmias discussion I've said that in AVR P wave is upside down, T wave is upside down. The normal P and the T is always upright. But in AVR, because it reads the heart the other way around, that is ulta, reverse, so P and T are negative, and instead of ST elevation, it will be written ST depression. Another lead where you may, I'm just writing plus minus after that, you don't need to note it down because that's not a sensitive finding. In V1, the ST elevation may be replaced by ST depression. Again, reciprocal change is not being talked about at the moment. Reciprocal changes are what are valid for myocardial infarction. Here I'm just saying that because it's a diffuse process, everything will show ST elevation except for the electrical circuit of the ECG is designed like that AVR will always show opposite findings. So AVR will be having a written ST depression. Now, lots of time I have seen people are able to remember this information. So instead of talking about ST elevation, he might say additional fact. The additional fact he will say will be PR segment depression. I'll just hand draw this in few seconds from now, but just get the theory right at the moment. You see, if ST is going up, it is going up with respect to something or going down with respect to something. No? So what is the baseline? The baseline is PR segment or PR interval. In this case, I'm using the word PR segment. PR segment will be from the end of the P wave. Mark my words there. PR interval is from the starting of the P to the beginning of Q. PR interval is from the end of the P wave. So the PR segment of this particular case will be showing a depression in all the leads, and if he says accept, the answer will still in these circumstances turn out to be same, that is going to be AVR, because that's how the electrical arrangement of leads around the heart is present. And at this junction I can just focus on this ECG. You will notice while I'm hand drawing it that after P I'm showing a slight PR segment depression, and then you are noticing presence of a R wave, and while the R wave is coming down, that is where I've highlighted a rather concavity which is present, followed by a T wave present here. So you can definitely notice a concavity in this case. In some of the cases, you might actually be noticing that the ST elevation concave might be a little prominent. In some cases, the T wave might actually be seen a little separately from the ST segment as well. The bottom line is that concavity will be very clearly visualized, and this would be present in all the leads. In contrast to myocardial infarction, in which we have discussed a finding which is grossly different. That's going to be convex, and there's a concomitant T wave inversion as well. So for MI, we have this classical Pardee sign. We have this being called also as tombstone pattern. I repeat the facts once again. Pardee sign, tombstone pattern are used classically to describe coronary event, which is thrombus in the coronary artery, that is myocardial infarction. And in MI, I never spoke about any PR segment depression. And this is with respect to baseline. This is the baseline. One part is going up, the other part is going down. Why this is happening is because atria are also involved. No, so there is a atrial irritation, there is a ventricular irritation which results in these abnormal vectors being generated. So ECG will definitely help you to confirm the diagnosis of this condition over and above the auscultatory findings. Subsequently, I will also be doing echocardiography in this patient. This is mainly to check for evidence of any kind of effusion present in a patient. Like for example, if it's a pericardial effusion due to malignancy, then I can subsequently be even doing or having the requirement of doing a pericardiocentesis, especially if it becomes towards or goes towards a tamponade, because tamponade will crush the heart. So you anyway need to do a pericardiocentesis to decompress the system and get the heart out of this mess of obstructive shock. For etiology, I can be doing a HRCT. In fact, there are multiple investigations that will be required to find out the etiology because there are so many causes which are responsible. HRCT test will mainly be helping you rule out a possibility of a cancer which has metastasized to the heart of the patient. So obviously multiple investigations are required here, and then subsequent to this, we'll initiate treatment. Now, when it comes to treatment of this case, If it is viral pericarditis, I will be having to give painkillers to the patient. I need to relieve the pain component, but I'll not give steroids. But if it is tubercular pericarditis, then I will have to give anti-tubercular treatment to the patient. If it is going to be Dressler syndrome, this is autoimmune in etiology, but we do not answer steroids. We rather give aspirin to these patients. The dose of aspirin would be 300 milligram. It might have to be given maybe 2-3 times a day. So we will take adequate care of preventing the drug-induced gastritis by giving mucain gel or Digene gel along with this. When it comes to uremia, the treatment will be hemodialysis, so KFT will obviously play a role. Biomarkers of kidney damage will definitely play an important role. If it is malignancy, then it is a malignancy induced damage, then we will have to plan a chemotherapy session for the patient depending on the type of cancer which is present. I wanted to say here before you that there is no cause specific treatment for pericarditis. It will depend on the etiology per se, that whatever we are going to use in the exam most of the time. This is the slide that you need to remember for the first topic here, acute pericarditis, how it presents, what is going to be the auscultatory finding, how will it be differentiated from findings of myocardial infarction. And one very striking feature which is seen in MI and not seen in this case would be breathlessness. Pulmonary edema is a very striking manifestation in myocardial infarction where the pumping action of the heart is compromised. Here the pumping action is doing very fine, so pulmonary edema will not be present. Even BNP levels will be normal in this case. Bat-wing pulmonary edema will not be present. So there's absolutely no reason why somebody can confuse MI presentation versus a pericarditis. And I said, whenever in doubt, look for evidence of pulmonary edema. No, look for fine crepitations written in the chest. If there is bilateral fine crepitations, then it cannot be a pericarditis presentation, because pericarditis per se does not result in pulmonary edema manifestations. So differentiation, I personally feel, is relatively easy. I shall now be comparing acute pericarditis versus pericardial effusion. You see, normal amount of fluid outside the heart for lubrication purposes can be in the range of about 20 to 50 ml. But if there's going to be a substantial amount of fluid increasing to, let me say, 100 ml, then the ECG of this patient will definitely help you identify the disease process, because there will be a low voltage ECG. The diagnostic criteria for low voltage ECG are two. If the height of the R and the depth of the S, where both have to be added in this case, is less than 5 mm in the limb leads, then it is diagnostic of low voltage ECG. If the height of the R and the depth of the S is less than 10 mm in the chest leads, it is again a feature of low voltage ECG. So one, you need to remember the criteria, and then you also need to remember some alternative conditions where low voltage ECG has been discussed. In endocrinology, you will always notice me saying low voltage ECG is a feature of hypothyroidism. So I've written an alternative term here, myxedema heart. Even in restrictive cardiomyopathy. Why? Because there's going to be fibrosis in the heart that will rather reduce the electrical vector or will reduce the current. Then can be constrictive pericarditis, where there's going to be calcification outside the heart that will again limit the electrical current and will cause a low voltage ECG in the patient. Now my point is that low voltage ECG looks very attractive as an answer for identifying pericardial effusion, but because it is seen in other conditions also, so we cannot say that this is definitely a confirmatory feature. So I will now hand draw before you how via ECG do we know it is a pericardial effusion. In fact, the question that came in the exam, my students told me that, sir, in the ECG, everything was looking fine. The P wave height and duration, PR interval, QRS duration, ST segment, everything was fine. The only thing that one of the brilliant chaps he noted was that the amplitude of the QRS complex was not same as what was present initially. In fact, it was fluctuating. Just be patient while I hand draw another QRS complex before you, and then it will become more obvious to you about the fact that I'm saying. If you look at the amplitude of the duration wise, everything, all the parameters are normal at the movement. But if you look at the amplitude of the QRS complex, this amplitude is varying. Now, why that is varying is because heart is moving in a bag of fluid. The heart is surrounded by this fluid. So when the heart will contract in this bag of fluid, this fluid will have a swirling motion. Imagine there's a fluid like in a mixie, right? In a mixie, when you're grinding something, in a mixer, when you're grinding something, there's a swirling motion of the fluid. Similarly, the heart is contracting. So so there's a swirling motion. That swirling motion of fluid that is present is actually causing a distortion of the electrical vector and is causing a change in the amplitude of the QRS complex. And this is a very classical term, guys, electrical alternance. A lot of MCQs of pericardial effusion will have the end point as what I'm teaching you at the moment, and they have given both image-based question on the same as well as at the same time they have given theory-based scenario. So I want you to remember that if he says which ECG criteria is best for identifying a pericardial effusion, the answer is not low voltage ECG as explained to you, lots of other causes. It is electrical alternance. There is a swinging movement of the heart axis. This fluctuation of the voltage, this fluctuation of the axis of the heart is because of the swirling fluid movement in and around the pericardial sac. I would also at this juncture try to remind you that if you get a ECG in the exam in which there is going to be broad QRS complex rather, but they are having variable amplitude, right? This time the voltage is again changing, but the voltage is changing not of a normal duration QRS, it is broad QRS, and the amplitude is variable. I repeat the fact once again. In the superior ECG, the blue one, you will notice a variable amplitude, but at least the duration wise it is normal. But in the inferior one, it's a broad QRS with the amplitude variable. This is a feature of TDP, that is Torsades de Pointes, also called as polymorphic ventricular tachycardia. So I'm going to highlight this fact again, that I have told you 2 times when the fluctuation of the voltage is occurring, but at the same time, one is for a normal duration QRS, the second one is for a broad QRS, so confusion between the two is less likely to happen once I've sensitized you towards it. Now I will be performing a chest X-ray in the same case so that I can be sure, and I will notice a substantially increased cardiothoracic ratio, and the examiner knows that I'll be able to pick it up. So you will see here very classical terms that are used, and even the radiologist will say about this, that is a water bottle heart, or instead of water bottle, he might say the word money bag appearance. I repeat the fact once again, water bottle heart, money bag appearance, or simply increased cardiothoracic ratio help you in picking up pericardial effusion. See, CT ratio increase can also occur even, I can say, with congestive heart failure. But in congestive heart failure, then you will also be having batwing pulmonary edema, congested neck veins will be present. Whereas in a pericardial effusion, initially, if it's only going to be like 70-80 ml of fluid, you may not have very grossly congested neck veins present in the person initially. This is what I'm saying. If they give you a chest X-ray, you will definitely be able to identify the cardiac borders. But now notice a slight disparity that I'll bring up here. What I'm saying is there is fluid outside the heart, and fluid will obviously gravitate towards bottom. So this is what I'm talking about, is the classical water bottle appearance or the money bag appearance present in this chap. And the term that will be used sometimes just to trouble you will be narrow vascular pedicle. What is meaning is like it's a sac, no? The fluid will gravitate to the bottom. The upper part will be relatively lesser, having lesser fluid or relatively empty. The sac per se I'm talking about. So narrow vascular pedicle, because that is where the blood vessels are. Aorta is present, pulmonary artery is present. So the narrow vascular pedicle, increased cardiothoracic ratio. And in fact, in these patients, one clinical finding can also come, though this is whatever finding that I'm saying is very, I would say, subjective and is prone to error. So what I'm writing right now, this is just for your understanding sake. Please do not note it down. Epigastric fullness will come. Why? Because there's a bag or there's a sac which is having excess amount of fluid. So this epigastric fullness that is appreciated by the patient has a classical sign also. Now, per se, I would say that this sign is not very famous one. Harrison does not talk about it, and you don't need to note it down also. I just want to say that Oenbrugger sign basically means that there's going to be substantial epigastric fullness present on the patient on the account of lot of water around the heart. Most of the time in the exam, they would love to ask you regarding pericardial effusion ECG criteria that I've sensitized you to alternative causes of low voltage ECG. And well, radiologically speaking, I don't think so there will be much problems for you, since you guys are gonna study this even in radiology and image-based section. Additional information that I would like to add up here is that how do you pick up right ventricular enlargement and left ventricular enlargement on a X-ray per se. So you need to look for the position of the apex per se. If right ventricle will enlarge, like in boot-shaped heart or tetralogy fallet, there is a boot-shaped heart, the apex will always be showing a superolateral displacement. That is because the right ventricle is inferiorly located, so it lifts up the apex of the heart. So you will always notice superolateral displacement of the apex. In case you notice that the apex of the heart is exhibiting a inferolateral displacement, then it would be signifying a left ventricular enlargement, and this obviously comes with practice also. In most patients of pericardial effusion, if diagnosis is made on time, great, but sometimes these patients can degenerate into cardiac tamponade also. So in my next diagram, I'll try to explain to you what I mean by the word cardiac tamponade and low pressure cardiac tamponade. This is the representation of the left and the right ventricles per se. Then I've also shown the atria, and I've shown the great vessels which would be emptying into the left and the right side of the heart respectively. In this sac, I have shown substantial amount of fluid present which is in excess of normal, and because there is limited space present here, so this fluid will automatically start putting pressure on the heart from outside. The term that I want you to get used to at the moment is called as low pressure cardiac tamponade. When I say this term, the usual query of most doctors is that, sir, on one hand you are saying tamponade and then you say low pressure. I mean, what is the difference? Well, the point that I want to make here, or the crux of this entire discussion, is that in low pressure cardiac tamponade, the pressure will be substantial to crush the atria. Like you can see the arrows that I'm showing, the pressure will be substantial to crush the atria, but this pressure will not be sufficient to crush the ventricles at the movement. So as such, in this particular diagram, at this juncture, all I'm going to highlight is presence of atrial collapse. Atria contribute 30% to filling of the ventricles, no? If there is gonna be fluid in the pericardial sac which is gonna press on the atria from outside, then the filling of blood that will occur in the left atria and then subsequently left ventricle will also be hampered. I've deliberately shown this filling of ventricles in this patient getting hampered due to the extrinsic pressure in the pericardial space. Now, as I highlighted, atrial collapse will contribute to decrease in the contribution of the atria towards ventricular filling. So there is a total of 30% decrease. You can refer to Benong for this. And I've in fact said that in heart sounds topic, and even when I've talked about cardiac contractility, that atria contribute 30% of the filling of the blood to the ventricles. If atria is not going to function, 30% filling of the ventricles will definitely be hit. If less comes in, less will be going out. So there will also be a mathematically 30% decrease in the systolic blood pressure of the patient, and therefore when you will check the pulse of this person, the pulse will be relatively feeble, or I can write the word weak. Now compare this with what I say next. At the moment, please stop noting and just focus on what I'm saying. If I say the word cardiac tamponade, or if in the exam you ever read the word cardiac tamponade, the thought process of yours is that this is high pressure cardiac tamponade. The thought process of yours, high pressure cardiac tamponade, basically means that now the pressure will be substantially increased to the level that it will not only contribute to atrial compression, but it will also result in ventricular collapse. Imagine so much of fluid outside the heart that it is crushing. I'm just increasing the vector here. I'm just going to do it twice to highlight that there is substantial amount of fluid present in this limited space that is crushing both the atria and the ventricles. So the filling will be dramatically reduced. And now the pulse of the patient might actually become so weak that it might even disappear. You will notice that there's a fundamental difference between one, I say pulse is feeble. Second, I say pulse I can't feel. See, I'm not teaching you cardiac arrest. Heart is still beating now. If I was teaching you cardiac arrest and pulse is disappearing, understandable. But here the heart is beating. Still there is no pulse. That is why we call it pulsus paradoxus. Guys, the paradox here is that the heart is beating and still the pulse is missing. So the main message I want to give you here is that pulsus paradoxus is a finding of cardiac tamponade but will not be found in low pressure cardiac tamponade. I repeat the fact once again, pulsus paradoxus is a diagnostic feature or one of the important features of cardiac tamponade but will not be encountered in low pressure cardiac tamponade. The reasons are relative compression. In tamponade, which you think as high pressure, there is a crushing of both atria and ventricles, whereas in low pressure cardiac tamponade, it is only the atria that is hampered. So as such, the pulse will become weaker but will not completely disappear. I shall now be explaining to you regarding the concept of pulsus paradoxus once again, but in a slightly different fashion. You see, during inspiration and expiration in our heart, variable amount of blood will be coming. During inspiration, the amount of blood that comes in is relatively more, whereas the amount of blood that comes in during the phase of inspiration is relatively lesser. I've highlighted this even earlier in my heart sounds discussion that in inspiration, because there is more negative pressure created, so more negative pressure will suck more blood towards the heart. As a result of this extra volume of blood, there will be a mild septal deviation. Though I've exaggerated the finding, but there will definitely be, to accommodate this blood, septal deviation occurring. And now what you can see because of this septal deviation is that the actual cavity size of the left ventricle will become relatively lesser. the left ventricle will be able to receive less amount of blood. If less blood will come in, stroke volume will also become less. If stroke volume will become less, the blood pressure will also become less. So I want to teach you the fact that on deep inspiration in you and me, I means inspiration, E means expiration here. On deep inspiration, the systolic blood pressure value of yours and mine will become relatively lesser. In fact, if I ask you to take a deep breath and hold it there, then your systolic blood pressure will not be 120, it might be only 115 millimeter of mercury. But when you will expire, then the amount of blood coming in the right ventricle will be relatively lesser, so the septal deviation will go away. Once the septal deviation will go away, the end diastolic volume, the stroke volume, the blood pressure values will definitely come back to normal of 120 millimeter of mercury. I have just highlighted a simple concept of physiology that blood pressure falls on deep inspiration. Now, over and above this, I'm going to show the pericardial sac in this patient. I'm also going to highlight that this pericardial sac, this is a two-dimensional diagram, guys, but the point is this pericardial sac is having large amount of fluid, so it will press on the heart from outside, and because of the pressure on the heart from outside, there will be definitely a exaggerated septal deviation. So I've just put another arrow or plus sign to say that the septal deviation that occurs in you and me as compared to a patient of cardiac tamponade, there is going to be difference, that this is going to be exaggerated. This will contribute to more fall of end diastolic volume, more decrease of stroke volume, more decrease of blood pressure, and as the blood pressure will become relatively lesser, the pulse might become so weak that you may not be able to appreciate it, and this pulse that is so weak that you are not able to appreciate is what is called as pulsus paradoxus. I again want to highlight, guys, that heart is beating here, but still the pulse is becoming feeble. It is becoming so feeble that you are not able to appreciate. Why? Because the exaggerated septal deviation in this case is going to limit the filling of the left hand side, and whatever I've written here before you is written in the textbook also as a reverse Barheim effect. So there are two ways by which I have tried to explain to you why do you get pulsus paradoxus. One will be, I would say, a relatively easier one to remember. That is simply that because there is pressure on the heart from outside, because there is a total crushing of the atria and the ventricles, hardly any filling occurs, the pulse will practically disappear or will become so weak that you will not be able to appreciate it. Second, I said a technical aspect that blood pressure tends to fall on inspiration. Here the inspiratory fall will be more, so the pulse will become more weaker and therefore it may not be appreciated. Let's just jot down the theory here, guys, and this is important for the exam. I first told you that in a normal person, the inspiratory-expiratory variation of blood pressure always occurs. This inspiratory-expiratory variation of blood pressure will always be associated with a fall. The word is fall. JVP falls on inspiration, blood pressure also falls on inspiration. The fall will be always less than 10 millimeter. If you read the inspiratory-expiratory variation of blood pressure in a person, the fall is occurring but is turning out to be more than 10 millimeter. In fact, in some books it may be written as even 12 millimeters of mercury. Then it signifies what is the technical definition in the textbook of pulsus paradoxus. The condition being talked about at the moment is cardiac tamponade. It's gonna put so much of pressure outside the heart on the heart that the inspiratory fall of blood pressure is going to be in exaggeration of normal physiology. I repeat that again. The inspiratory fall of blood pressure is going to be in exaggeration of normal physiology, and the pulse might become so feeble that you may not be able to appreciate it, though it is very much there. Now, since lots of us are able to retain this information deliberately in the MCQ, he may not be having cardiac tamponade as one of the causes of pulsus paradoxus. He can actually put up another cause per se. And another cause that I want you to remember for pulsus paradoxus per se can be status asthmaticus. He can write status asthmaticus, he can say severe acute asthma. See, respiratory conditions, they can deliberately introduce in the MCQ, because he knows that your thought process or you are focused on cardiology, so he'll try to incorporate respiratory condition in the question. The next time you will read pulsus paradoxus will be again from pulmonology, that is acute scenario of pulmonary embolism or acute cor pulmonale. You can go through the respiratory section for this. Acute cor pulmonale occurs whenever a person is having a massive pulmonary embolism. This clot will block the pulmonary artery circulation. If you block the pulmonary artery circulation, hardly any blood will go towards left, and therefore the BP will anyway crash and the pulse might totally disappear. Problem is on the right side of the heart. The clot went from right atria, right ventricle. The patient was having DVT. The clot came into the right side of the heart, entered into pulmonary artery, and then blocked a branch of the pulmonary artery. So if no blood will come to left side, obviously the BP of the person will crash and the pulse will be so feeble that you will not be able to appreciate it. Another important cause that should be remembered is pregnancy. In pregnancy, the issue is that the gravid uterus can actually be pressing on the inferior vena cava, reducing the venous return dramatically, and therefore these are some important causes which they love to ask. And the last I'm mentioning constrictive pericarditis. After constrictive pericarditis, they're mentioning the word rare per se, but yeah, if there's a calcification outside the heart, again the filling of the heart will be compromised. Anyway, the septal deviation process will occur. So I can put it like this: in cardiac tamponade, it is fluid that is encasing the heart, which is contributing to problem. In constrictive pericarditis, there's going to be a calcification. Obviously, the amount of calcification can vary. If it is less, you may not get a pulsus paradoxus, but if it is sufficient in those circumstances, because it is limiting the expansion of the heart, it is limiting the filling of blood in the heart, again the reverse Barham effect can contribute to pulsus paradoxus to develop. If he says during checking or evaluation of pulsus paradoxus, what should be the breathing pattern of the patient? So we will not advise deep inspiration or deep expiration. I want you to remember this once again. It is normal breathing that is recommended whenever you are checking or evaluating whether person is or is not having pulsus paradoxus. I repeat the fact once again. The question said while evaluating pulsus paradoxus in a patient, the inspiratory expiratory variation that is going to occur in excess of physiology. Normally less than 10 millimeter, here it will be more than 10 millimeter. What should be the breathing pattern of the person? Will you ask him to take a deep breath, hold it there? Will you ask him to do deep breaths, hyperventilation, hypoventilation? It's just normal breathing, and you can check the BP with respect to the variation of respiration, and with respect to deep inspiration and expiration, the values that you will come or you will notice will be different from what actually happens, in a sense that the value of fall of blood pressure normally is less than 10 millimeter. Here it is exaggerated, it is more than 10 millimeter. I said the same thing once again. Why? Because now I want to teach you about a condition called as massive pericardial effusion. In fact, at this junction, I would suggest you to stop taking notes and listen to what I say, because a bit of mathematics, very simple one, is coming up, but the concept has to be clear. You see, suppose you are having a person of hypothyroidism. You have started the person on levothyroxine, that is L-troxin tablets, but the person is not regular with that, and therefore the lymphedema component will contribute to fluid outside the heart. When you say the word mixed edema, it's actually a lymphedema only, na? So fluid accumulation is occurring around the heart, but it is lymphatic fluid. Now let me say about 20 ml extra lymphatic fluid is accumulating around the heart of this person per year. So if the person is not going to take treatment for next 20 years, this 20 into 20, this would mean about 400 ml extra lymphatic fluid outside the heart. But because it is going to take large number of years to develop, mark my words there. You see, I'm not saying that amount has increased to 400 ml in a matter of weeks or months or even days. I am saying this increase has taken 20 years. So because this is a very slowly developing process, therefore the heart will get used to the pressures. Mark my words there. I said because this is a gradually occurring process in mixed edema heart, that the extra fluid is putting pressure on the heart, so the heart is getting used to the extra pressure. So in patients of mixed edema heart / massive pericardial effusion, the heart is getting used to it, so pulsus paradoxus is not seen. In fact, there are 2 times when I have taught you today that pulsus paradoxus is absent. First, I'll just go back in the slide. When I started the topic of cardiac tamponade, I taught you low pressure cardiac tamponade. We do not have pulsus paradoxus. It is plain cardiac tamponade / high pressure cardiac tamponade where we have pulsus paradoxus. And right now, I have just added to your vocabulary this extra point that pulsus paradoxus is also going to be absent in massive pericardial effusion, because the heart will get gradually used to it. The causes of pulsus paradoxus are the ones which are enumerated here and definitely should be remembered. Next, to see whether you've understood the concept of cardiac tamponade that I've explained to you, I'll be describing a clinical case before you, where I'll be describing a person who's driving under the influence of alcohol and had a car crash. Now this guy, he under the influence of alcohol is thinking that he's a Formula 1 driver. Obviously that is illegal, but you would have seen so many young people nowadays driving under the influence of alcohol, and they think that they can obviously drive, which is totally wrong, and they can misappropriate the distances with respect to the next vehicle or maybe a stationary vehicle. So unfortunately his car hit the backside of a truck. The truck had broken down bang in the middle of the road. It was relatively dark. He was going back from a nightclub, and he was alone in the car, and the seat belt also off. If the seatbelt is off and there is a sudden deceleration injury, the body will slam into the steering wheel, so there will be direct impact on the heart as well as on the lungs. Luckily, somebody reported this accident and the ambulance reached the site, and the ambulance crew is now talking to you on the phone and are describing you the actual scene of the crash. The ambulance crew is telling you that, sir, the patient is still breathing but is trapped in the car, so they have requested maybe the fire brigade to come and use that gas cutters to cut the chassis of the car and extract this individual. So you ask the medic, okay, check the vitals of the patient. He has reported that the heart rate of the patient / pulse rate of the patient is very fast. You asked him to give you the value. He said something in the range of 130. You asked him, well, the driver is still trapped in the car and they are working with gas cutters to extract his body, check his blood pressure. So since his arm was accessible, blood pressure was about 80 millimeters of mercury. The patient was not talking, or let me say he was very groggy. He was slumped over the steering wheel. So the ambulance crew actually waited for a while so that they can extract his body out. And after that, they asked you on the call itself that, sir, since his BP is so less, should we put a IV cannula? So you said a yes to that also. That will obviously take a few minutes only, but yeah, you did give permission to start the IV cannula, and even IV fluids were initiated in this person. A drip has been initiated, cervical collar has definitely been placed, and this person was rushed to the hospital. The transport to the hospital occurred within few minutes, let me say 15 to 20 minutes of the actual accident. But unfortunately, when this person reached the hospital, either he was dead on arrival or died on arrival to the hospital, or within few minutes of arrival to the hospital, whatever be the scenario. The question that came in the exam was about 4 to 5 lines. He described the accident scene, he described the vitals of the patient, and then he asked, why did this person die? Now, obviously, one of the causes can be direct trauma to the heart and cardiac tamponade, but let's look at the actual options that came in the exam. One of the options was vertebral artery dissection. Now, this is definitely a possibility because you see, first the body will move with the speed of the car, so the neck will be thrown forwards and then suddenly backwards. So, sudden hyperextension of the neck can contribute to a vertebral artery dissection that can cause a brainstem ischemia, a brainstem stroke, and brainstem is where the vital centers like respiratory center, vasomotor center are. So the breathing effort of the patient will definitely be hampered. The blood pressure can crash. Next possibility is that maybe the steering wheel impacted the lower part of the abdomen, so therefore there can be rupture of either the liver or the spleen. In fact, I can say that the trauma actually occurred in the lower part of the chest and a relative upper part of the abdomen, so hemoperitoneum can occur. Another possibility can be that this guy's ribs broke and they damaged some important artery, so hemothorax is occurring. And the last possibility is the obvious one, that is hemopericardium, which can occur with respect to such a fast deceleration injury. Now we have to rule out these options one by one. So if I go stepwise, I'm ruling out vertebral artery dissection because whenever there's going to be injury to the brain, it will be associated with bleeding and raised ICP. And whenever there is a raised ICP, there will be bradycardia. Look at the vitals of the patient. There was a tachycardia, whereas you are aware from CNS domain and even in physiology they teach about Cushing's reflex. I have ruled out option number A here primarily because in Cushing reflex you get a bradycardia. In this case there was a tachycardia, BP was low, whereas in raised ICP blood pressure should be on the higher side. Let's look at 3. Hemoperitoneum. Is it that a steering wheel impact can cause a rupture of the liver and a rupture of the spleen? Yeah, it is possible, but the point is most of the time this is less likely, and over and above, hemoperitoneum will cause hypovolemic shock. In fact, both point number 2 and 3 will contribute to hypovolemic shock, and hypovolemic shock will respond to IV fluids, whereas in our case, the person expired on the way to the hospital and reaching the hospital because he was not actually in hypovolemic shock. Hypovolemic shock responds to IV fluids. See, the decision of me as a doctor here was wrong. I allowed IV fluids to be started. I allowed IV cannula to be put. That wasted a couple of precious minutes. Actually, if this person was brought to the hospital maybe a few minutes earlier, I would have been able to treat this patient better. What actually happened was that the trauma to the chest contributed to hemopericardium. This resulted in cardiac tamponade and causes crushing of the blood pressure of this patient, because in tamponade, which I casually said as high pressure cardiac tamponade, both atria and ventricles are crushed. his own blood is crushing his atrial ventricle, so the filling into the heart is compromised. So the blood pressure of this guy was really, really low, and by the time he reached the hospital, the person unfortunately expired because he developed obstructive shock. It was wrong on my part as a doctor to give fluids to somebody with obstructive shock, because even if you give the fluid, how will they reach into the ventricular cavity when the ventricles are crushed by the patient's own blood from outside? It was wrong decision. I could have saved a few minutes had I said no need for IV cannula, bring him to the hospital. In the casualty, I could have actually done a bedside echocardiography or maybe a fast scan that can also scan the evaluation or scan the heart per se, and I could have actually saved this person's life by doing a pericardiocentesis. The basic message I want you to remember from this discussion is that I agree that in polytrauma there can be multiple reasons why a person can die. It could be simply that the neck of this patient is injured so bad that the vertebral artery was compromised and there is a bleeding with respect to vertebral artery and even to the brainstem. That's one possibility. Especially in Formula 1 races, there's a possibility that it is cervical spine injury and most importantly, I would say vertebral artery dissection that contributes to death. But if a seatbelt of a person is off and the person takes a direct impact on the chest, hemopericardium, cardiac tamponade contributing to obstructive shock is the main reason for death of the person. And then they gave a same MCQ once again, but they slightly modulated the question. So what you can do is in your notes, instead of writing the word off, you can change it to seatbelt on. Seatbelt was on, driver was trapped in the car, the chassis of the car was all mangled, they used gas cutters etc. to extract this guy. Everything is same, fluids were also given, but the person still expired. Then what could be the reason? Guys, if the seatbelt is on, then the problem is that the seatbelt, like in a Indian car, you have a right hand drive, so the seatbelt will go from your right shoulder downwards right to your left pelvis, and the mesentery goes perpendicular to that. So there can definitely be a mesenteric tear. I repeat the fact once again. If the seat belt is on, then in Bailey and Love you will read regarding what is called as seat belt syndrome. In seat belt syndrome, there will be unfortunately a mesenteric tear. The bleeding will be occurring with respect to superior mesenteric artery, inferior mesenteric artery and their branches, and this can again be lethal and can cause hemoperitoneum. I mean, I agree, I gave IV fluid, but because it's an arterial bleed, the chances of saving the patient might be relatively lesser. The learning point for us is that whenever it comes to a car, well, the car should be having adequate safety features and should be driven with a proper speed, respecting the rules. In case of a person who's intoxicated, the anticipation of distance between two vehicles is definitely hampered, so he will hit on the brakes later. So the chances of a person having an accident will dramatically increase. So seatbelt off is definitely a disaster because that will contribute to hemopericardium and a cardiac tamponade. But even when the seatbelt is on, the danger is not over. It can actually cause a mesenteric tear as well. The answer to this question is hemopericardium. Because cardiac tamponade is what they love to ask in the exam, I will spend few more minutes on it. Cardiac tamponade we have discussed today, pulse, blood pressure finding. I'll add up the JVP findings here and the heart sound findings for this person. I've already explained to you that when you will check the pulse of this person, he should be taking normal breaths. You will notice that there will be an inspiratory fall of blood pressure more than 10 millimeters, whereas normally it is less than 10 millimeter. Or the pulse will be so weak that you may not be able to appreciate it in between. Since the BP is crashing in this patient, he will ask you what kind of shock you have learned. IV fluids are contraindicated in a person suffering from obstructive shock. The JVP of this person will definitely be elevated because there is pressure on the heart from outside. In fact, I want to teach you that cardiac tamponade is one of the important conditions where you will always read about non-pulsatile elevated JVP. Look at the words that I'm writing here. Non-pulsatile elevated JVP. JVP is normally always pulsatile. The column will always fall with deep inspiration and Kussmaul sign it will rise. But in this case, I'm teaching you there will be no Kussmaul sign that is appreciated. Why? Because normally Kussmaul sign is going to be the rise of the JVP in this particular case because the column will become non-pulsatile. So you can't see the pulsation. You can't see whether it is falling or whether it is rising. See, Kussmaul is rise. If it is non-pulsatile, you cannot see whether it is rising or not. So Kussmaul sign is absent in cardiac tamponade. I have explained this to you guys. Kussmaul sign is found in CRR, constrictive pericarditis, restrictive cardiomyopathy, right ventricular MI, right-sided heart failure, but is not seen in cardiac tamponade. Why? Because the JVP in this case is non-pulsatile. In fact, there are two scenarios where you will always read about a non-pulsatile elevated JVP. One is superior vena cava syndrome / superior vena cava thrombosis. And second is the topic that we're studying at the moment, cardiac tamponade due to external pressure from outside. The pulsations are literally going to disappear. The heart sounds aspect is relatively easy for everybody to comprehend. They will be distant heart sounds or it will be written as muffled heart sounds. These three that are marked before you with a star are always taught in surgery as well with respect to Beck's triad. And you can see another question that came up here was that which is not a component of Beck's triad. So pulsus paradoxus that I initially explained for this topic is not a component of the Beck's triad. At the same time, if I'm going to do a chest x-ray in this guy, the water outside the heart is more because there's a substantial amount of fluid. So I am saying water bottle heart, and I'm just putting a double plus in front of it to say there is more water around the heart or more money outside the heart. In the same sense, if I do ECG in this person, the electrical alternance component of the patient will be more severe than what is anticipated in pericardial effusion. If pericardial effusion versus tamponade is considered, pericardial effusion is fluid outside the heart. The fluid might be minimal, it may not be crushing the heart, but in tamponade, it is literally squeezing the heart from outside. So therefore, because of this crushing, the blood pressure crashes and all the parameters are exaggerated. Why that is important for you to study is because if you read a question in which a combination of pulsus paradoxus and electrical alternance is given, this double plus sign may not be given. All I'm saying is if it just says pulsus paradoxus and electrical alternance also described in a 3 or a 4-liner MCQ, it means it is cardiac tamponade. But suppose in the exam they give you a question in which only electrical alternance word is given. If only electrical alternance word is given, that implies the fact that the answer should be given as pericardial effusion. I repeat the fact once again, guys. If you read a question in which the findings given in the ECG is electrical alternance alone, it is effusion. In effusion, because there is minimal pressure or no pressure on the heart, as a result of it, the pulse will be normal. But if you take the mega version of it, what I mean by the mega version of this is cardiac tamponade, it's going to crush the heart, and that is why pulsus paradoxus will come in. So do remember this aspect that alone electrical alternance is pericardial effusion, and a combination of pulsus paradoxus with electrical alternance is a feature of cardiac tamponade. The treatment of choice for cardiac tamponade will be echocardiographic guided pericardiocentesis. Obviously, we should never try a blind puncture because you never know where the needle is going. In fact, since I introduced an example of a car crash, there are two domains that I've discussed even for a car crash. So let's have a look at them again. Suppose after a car crash, he says that the patient's findings are on auscultation, distant heart sounds or muffled heart sounds. The JVP of the patient is grossly elevated. Non-pulsatile if written is a bonus point for you. And the BP of the person is crashing. It is definitely implying that the damage is to the heart of the patient. But if he mentions regarding presence of loud S1, tachycardia, anytime in shock, they will be loud S1. He mentions that the BP of the patient is crashing, but there is no information with respect to the JVP. Rather, instead of that, he might add an additional feature that the person is having abdominal bruising or abdominal distension. In those circumstances, I am thinking in terms of trauma per se to the abdomen of the patient, either the vital organ like liver spleen is hampered or the mesenteric tear has occurred in the patient. The left hand side, the information that I have written in the box is diagnostic or suggestive of diagnosis per se as obstructive shock. IV fluids are never ever to be given in obstructive shock. In contrast, on the right hand side, the findings are suggestive of hypovolemic shock, so wide bore cannula should be deployed and then the fluids should be administered. In the left hand side, post an obstructive shock, I will be doing an echocardiography and then echocardiographic pericardiocentesis, because lots of MCQs, he may not ask you what is the type of shock, he might just say what is the first investigation, what is the step in management. It is echocardiographic guided pericardiocentesis. For the right hand side, we will be doing CT abdomen. In this case, since the BP is crashing, unrecordable, so I can do a CT abdomen or fast as you will study in surgery, and then subsequently we will have to do a exploratory laparotomy in the patient. In fact, for the right hand side where they talk about a car crash, mesenteric tear, you can read about this from the surgical domain as well. But the core issues I've highlighted is that they will give you a scenario of a car crash and ask you what is the next best investigation. So you need to keep a mind open. Obviously, both things can also happen in an individual. That is, the seatbelt might be torn subsequently. Right, so there might be chest. I mean, if it's a very high velocity crash, initially it's causing damage to the abdomen. Polytrauma can occur, cervical spine trauma can occur. So multiple types of injuries are possible. Here I'm just creating a scenario for you that either of the two will be asked to you from the exam perspective, not a case of polytrauma. So you should be ready with the investigations and the treatment that we will do in this case. The topic that I've explained to you at the moment is cardiac tamponade, and now I'll be comparing this with the next one in the agenda, that is constrictive pericarditis. Now, a very special auscultatory finding of constrictive pericarditis I want to remind you is pericardial shudder, also called as pericardial knock. Why constrictive pericarditis will develop in a patient is mainly that it is a sequelae. Either it can be a sequelae of pyopericardium, like this person developed pus in the pericardial space, which could be secondary to extension from empyema, or it could be sequelae of tubercular pericarditis. In both the scenarios, the symptoms will develop after months and years. Now the issue is right ventricle will be having less muscle, left ventricle has more muscle, so right ventricular decompensation features will appear relatively earlier. You see, because in constrictive pericarditis there is a calcification limiting the filling of blood in the heart. Therefore, since it is encased properly with calcification, it is not able to relax, it is not able to get filled with blood. So since the compliance of the ventricles will be hampered in this case, I am going to describe to you what will be written in the MCQ for condition where RV compliance is lesser and LV compliance is lesser. If blood is not able to come properly in the right ventricle, then there will be ankle edema or pedal edema developing in the patient. Since the pressure in the portal will begin to rise, there might be ascites. But at the same time, you can easily rule portal hypertension as a cause is because in portal hypertension, which is usually due to alcoholic cirrhosis, liver will not be felt, but in this guy, he will say hepatomegaly. This will be a painless hepatomegaly. So instead of writing hepatomegaly, he might again say the word abdominal fullness in this patient. But the point I'm trying to make is that all these features are going to indicate compliance with the right side being hampered. If left side of the heart is not able to receive the blood, there will be pooling of blood in the lungs. It will contribute to pulmonary edema. I repeat that again. Left side of the heart should be receiving blood from the pulmonary circuit. If the pressure is going to be elevated, there will definitely be pulmonary edema. So they can be dyspnea on exertion, dyspnea on rest. Obviously, the examiner will take his own sweet time here describing orthopnea, paroxysmal nocturnal dyspnea. All these features are signifying pulmonary edema and then even effort intolerance. And when you are going to be reading this MCQ in the exam, your impression will be this is a question on congestive heart failure, because all these findings that I've written before you are given even in congestive heart failure also. So what should be written over and above this are some pointers that I'm going to teach you in the subsequent slide. These are what should be given in a multiple choice question over and above the features which have been highlighted here, which will tell you that, okay man, this is not going to be a plain congestive heart failure, this is constrictive pericarditis. The first one I've already sensitized you to. This is pericardial shudder. This is discussed even in the topic of heart sounds. Pericardial shudder is occurring almost at the same time as the third heart sound. The alternative names are knock and shock. As I've highlighted, pericardial shudder is a diastolic event. I'll just draw a sketch here to highlight what I mean by the word pericardial shudder. In this case, let us take this to be the, I would say, the cardiac muscle. And when the blood will strike this cardiac muscle in a normal person, the heart can definitely dilate. You see, the cardiac fibers in you and me are definitely gonna be contracting, but they're elastic also in a sense that they can accommodate the blood. So as contrast to a normal individual, the person that I'm discussing at this scenario, you see this is the thick calcification. It's a very irregular calcification that will encase the heart from outside like an egg shell. So when the blood comes into the heart, it will hit the muscle, it will try to dilate the muscle, but at the last movement you can see, because of the encasement by the calcified sac from outside, the blood will not be able to cause a substantial normal distension of the heart like it happens in you and me. The blood is hitting the muscle and then is bouncing off. Why? Because there is a non-compliant ventricle. This non-compliant ventricle is because of the thick zone of calcification outside, and this bouncing of blood against a non-compliant ventricle will set off a turbulence, and this turbulence is what is picked up by a stethoscope as pericardial shudder. Another feature that can be given to supplement what I have just said would be Kussmaul sign. In fact, Kussmaul sign has been discussed a couple of times, so should be relatively easy for you. I have taught you that Kussmaul sign is what we see with constrictive pericarditis, restrictive cardiomyopathy, and right-sided myocardial infarction. In fact, Kussmaul sign is elevation of JVP on inspiration. I'm just writing that in bold to highlight that in a normal person, JVP should be falling on inspiration. Additional information that will be given will be steep X and steep Y. I hope you recall in JVP lecture I've told you if it is steep X and absent Y, it is cardiac tamponade, whereas if you get both steep X and steep Y, this is going to be constrictive pericarditis. Additional information to be remembered is because atria will be working with stiff ventricles. I repeat the word here. There is stiffness outside the heart. Why? Because there is a substantial amount of calcification. So when the blood will try to enter during atrial systole, the atria are working harder because of the stiffness around the heart. So therefore this person will also be having S4 present. I repeat the fact again, why S4 is present is because the left atria is having to work against a resistance. Over and above this, even pulmonary edema features will occur in this guy. So he will talk about bilateral fine crepitations. If you look at the findings that I have highlighted before you, I agree that fine crepitations can be found even in congestive heart failure. But if you look at the information provided in this slide in the right perspective, I mean fine crepitations, fourth heart sound, steep X, steep Y, small sign, and pericardial shudder. If you combine all this information together in a 4-liner, 5-liner MCQ, the clinical diagnosis should be the topic that we are studying, constrictive pericarditis. Over and above this, when you go ahead with the workup of these patients, again substantial, I would say very good information can be given in the question, especially with respect to chest X-ray, because calcification can be picked up. I mean, if he gives you this word, egg in a cup appearance, that is excellent. But even if egg in a cup appearance as a word is not given in the question, still, I am definitely doing a chest X-ray because I'm ruling out congestive heart failure. No, otherwise I could have thought this could be cardiomyopathy also. This could be restrictive cardiomyopathy also. So as such, if the size of the heart is normal, it is ruling out other types of cardiomyopathies. At least dilated can be ruled out. At least hypertrophic variety can be ruled out. Then I'll be doing ECG in this chap because there is a calcification outside the heart. I have already sensitized you to this low voltage ECG. The imaging modality of choice for these patients is a cardiac MRI. I want to highlight this fact, either cardiac MRI or CT chest. Why I'm saying cardiac CT chest, both of them, is because in lot of MCQs cardiac MRI may not be given because of lack of availability, but CT chest can pick up calcification around the heart. No, one of the best ways to identify calcification is CT chest. The surprising thing that I am teaching you at the moment is that we are discussing cardiovascular diseases and I'm telling you CT chest. Why? Because calcification can be picked up. The language of the question was imaging modality which is preferred. The first answer is cardiac MRI. Please remember, MRI can differentiate between whether there is calcification outside the heart or whether there is fibrosis in the wall. Please remember, fibrosis in the wall is a feature of restrictive cardiomyopathy, and restrictive cardiomyopathy is one of the important differential diagnoses of this condition. When we were not having these imaging modalities available, in historical perspective, they will love to talk about this test called as endomyocardial biopsy, because endomyocardial biopsy will help you in evaluating restrictive cardiomyopathy, and if RCM is not there, then the diagnosis can be constrictive pericarditis. Endomyocardial biopsy is being done to rule out restrictive cardiomyopathy, though you can understand when you tell a person that we are going to take a biopsy in India, biopsy would be like taking a piece of the heart, no? So, I mean, person is going to freak out. I mean, sir, are you serious? So, lots of time person may not be willing to get this procedure done. Another investigation that can be done in this case is echocardiography. You can also switch on the Doppler to check for the pressure situation in the ventricles. And over and above this, please remember cardiac catheterization, which is again invasive, but they love to talk about this also in MCQs. The cardiac catheterization finding which will be present in this case will be secondary to the bouncing of blood against a non-compliant ventricle. So the term that is used is called as square root wave sign. Square root wave sign has been discussed even in cardiomyopathy topic with RCM. I have just highlighted that how would I try to differentiate restrictive cardiomyopathy versus constrictive pericarditis, and we definitely have a treatment available for patients of constrictive pericarditis. In restrictive cardiomyopathy, unfortunately, it's a cardiac transplantation. You obviously have backups like implantable cardioverter, defibrillator, warfarin to be used because there can be chances of development of stroke in a person of restrictive cardiomyopathy thanks to the fibrosis which can trigger clot formation. But in this case, there is no need for changing the heart per se. Pericardial stripping will definitely help in reducing the disability associated. I will now be presenting before you the summary of the important aspects that have been discussed for this particular lecture. You see, we have to differentiate between MCQ of acute pericarditis versus pericardial effusion versus cardiac tamponade and constrictive pericarditis. So I'm not discussing 4 different MCQs. I'm saying in a single question, if these 4 options are given, what are the words that will be written that will help you in differentiate? In earlier times, constrictive pericarditis used to be so severe or could be so severe that even it will cause adhesions with the chest wall. So lots of time in the traditional textbooks you will read systolic retractions of the chest wall. Apex beat is having a retraction. Why? Because there is an adhesion between the heart and the chest wall. So when the heart will contract, it will pull the chest wall inside. That is why I said systolic retractions of the chest wall. But at the moment, I would say that the constrictive pericarditis as a disease has become relatively less common, obviously because of us being able to identify and treat the causes in a preemptive mode. Now, acute pericarditis will always be having a ST elevation concave in upward direction. I have shown you an image of that already. I'm gonna bring it to your focus and attention once again. And lots of time he might mention except the answer is AVR, or he might talk about a PR segment depression. This is the image that I'm talking about. You can see a very characteristic ST elevation and a PR segment depression. When it comes to a question of pericardial effusion, there will always be this classical term written electrical alterance, but then you will have a combination coming up. I want you to remember that if in a question he's talking about both. So towards the end of this discussion, I would like to give you a summary of these various diseases that I have highlighted. In acute pericarditis MCQ, you will always be looking for this finding given ST elevation which is concave in an upward direction, and instead of this he can also mention a PR segment depression as well. For pericardial effusion, the classical term that should always be written before you comment on the diagnosis is electrical alternance. Whereas when it comes to cardiac tamponade, then two things should be given together. Pulsus paradoxus should also be written and electrical alternance should also be written. This combination should usually be remembered because you see Beck's triad is per se either given in surgery MCQs or is usually not given. I want to highlight because Beck's triad is too easy for any competitive exam, so I will just write it for the completion sake, but as such I personally think that it is too easy and everybody is able to answer it. So at least in internal medicine you will find cardiac tamponade questions mainly talking about pulsus paradoxus and a combination of electrical alternates, or you can talk about JVP binding of steep X and absent Y. On the right hand side for constrictive pericarditis, first I want to highlight pulsus paradoxus can be encountered even in constrictive pericarditis, though it is relatively rare. Why? Because there is an encasement around the heart, so the filling is compromised. There is a septal deviation already occurring in the person, but because of the encasement, the filling will be lesser than what it ideally should be. You see, in you and me, there is only a septal deviation that can limit the filling. In this patient, two factors are operating, septal deviation also and the calcification part also. So the combination of the two can cause substantial low filling, and therefore the pulse might become so weak that it might actually disappear, or the pulse pressure will dramatically reduce. But because in this question or in this topic there is a calcification outside the heart, so therefore due to calcification you cannot have electrical alternance. Calcification will cause a low voltage ECG. So when you are attempting the questions, read with lot of care. Don't be under impression that if he is given pulsus paradoxus, it implies cardiac tamponade. That's the point that I'm trying to make. It could be pulsus paradoxus and electrical alternance is not given, and the entire perspective of the question will change. The additional features that can be given is egg in a cup appearance. Now this is obviously optional on the examiner if he wants to make it easier for you. Then would be auscultatory finding of pericardial shudder. I personally have seen that most examiners love to use the word pericardial shock, because when they say shudder, no, your thought process is what is the shudder, what's the turbulence, so you might be able to figure it out. So he might just say the word pericardial shock because he thinks that you might actually start thinking in terms of various varieties of shock. If he gives you JVP funding, this question should be a piece of cake. I mean, if he's himself saying steep X and steep Y, then you don't need to focus on anything else. Only time when you read steep X and steep Y is constrictive pericarditis. And if he gives you a finding with respect to cardiac catheterization, which can be visualized even on a Doppler of blood hitting the wall and bouncing off, square root wave sign, then again that I would say is a bonus for you, in a sense that these are very classical terminologies that will help you identify these conditions. In fact, the summary that I've given you guys, this is a must know for you. I would suggest you to practice this and ideally write it. Try to write faster than what I have said here, under I would say 1.5 minutes, so that your brain is able to work fast when they give you a 4-liner in the exam, right? Most of us have a simple one word, thought paralysis. because we start thinking, okay, this could be a possibility. Exclusion skills will come with time. When you will do MCQs, obviously the exclusion skills you will develop, and all of you are intelligent enough to have capability to rule out two. It is only the remaining two options that will always be causing trouble, and that is where your fast thinking and effective thinking will play a difference. So whenever I mention a summary, I would suggest you to at least practice it so that you definitely can improve your strike rate. And you brilliant chaps, you are doing great. While reading this cardiology, you coming towards the end of it. So I definitely like to congratulate you for that. And yes, I mean, keep hammering, keep focusing, keep on doing questions daily. Make every day count. Learn a new topic every day, and you will yourself see after 15-20 days now your confidence levels will start increasing. You will feel more confident about just being a doctor yourself. Thank you so much for your patience and hearing me out.